Hi friends, look at this question. A 65-year-old smoker, so elderly smoker, presents with cough and hemoptysis. This is actually a stereotype. Elderly smoker presents with cough hemoptysis. Probably it is pointing towards a malignancy. Chest x-ray is shown here. What do you see on chest x-ray? There is a big opacity in the apex. Could it be a loculated effusion? Could it be a cyst? Could it be a tumor? But there's something which is given in the history that is really going to clinch the diagnosis. And what is that? See, there is a left apical mass lesion which is seen here. And along with that, there is left-sided Horner's syndrome because of the involvement of the cervical sympathetic ganglia, and also left upper limb pain and paresthesia, probably because of involvement of the brachial plexus nerve roots. So all this invasion or involvement of neural structures points towards a malignancy. There is a specific type of lung tumor or malignancy which is given a specific name when it occurs in the lung apex. It presents with a specific clinical syndrome, and that is what is being discussed here. It is called Pancoast tumor. What is Pancoast? How to diagnose it? What is the investigations? We will discuss this as we go ahead in this particular session. See, this is actually based on a clinical insight that we are going to study. All the lung carcinomas for diagnosis require CCT thorax. That is investigation of choice for all lung cancers. But MRI is useful in which of the following? So there is one exception to this rule, and the question is asking you about that particular exception, right? So this is again a very interesting discussion that is we are going to have. We'll discuss this as we go ahead. See, a recently asked question. A middle-aged female presents with fever, weight loss, and elevated AC enzyme, angiotensin converting enzyme levels, right? So this is very specific. This is clincher for one particular diagnosis. Chest x-ray reveals convex hilar shadows as shown here. So the hilar shadows on both sides are convex. Why? Because there are hilar lymph nodes which are there. So middle-aged female with non-specific complaints, elevated AC levels, right, with bilateral hilar lymphadenopathy, this points towards a specific diagnosis, and that is sarcoidosis. What is seen in sarcoidosis? How to clinch the diagnosis is something that we will discuss. Now, mediastinum, one conventional anatomic way of classifying or dividing the mediastinum is to say that the heart, pericardium, trachea lies in the middle mediastinum. Everything in front of it is anterior, everything behind it is posterior. But this creates a lot of confusion because there are certain structures which then pass from mediastinal compartment to compartment, and therefore what is more accurate is the radiological or Felsen classification. What is this Felsen classification? See, it states that, there are two lines which are drawn which divide the mediastinum into anterior, middle, and posterior. What are these two lines? The first line is drawn along the back side of the heart here and along the anterior margin of the trachea. This is the first line. The second line is drawn along along a line which connects the dots which are placed around on the each thoracic vertebra, but where? Around 1 centimeter posterior to its anterior margin. So this is the anterior margin. There are points which are marked on the vertebral end plates around 1 centimeter posterior to its anterior margin, and then a line is drawn across all of these points, right? And this is how the second line is drawn. Now, when we draw this particular lines, everything that lies in front of the first line is called anterior mediastinum. Whatever lies in between two lines is middle mediastinum. Whatever lies posterior to the third line is the posterior mediastinum. This particular line along the vertebral bodies is the posterior mediastinum. Now, the main content of anterior mediastinum here becomes the heart, the thymus gland, the retrosternal extension of the thyroid that can occur comes into the anterior mediastinum. Middle mediastinum basically has the trachea, the esophagus, the lymph nodes, right? And posterior mediastinum, according to this classification, mainly has the neural elements which are coming out from the spinal canal. Yes. Now, when we think of mediastinal imaging, rather mediastinal tumors, say, or mediastinal focal abnormalities or pneumomediastinum, the first investigation usually done is a chest X-ray. Though on chest X-ray, certain findings can be identified, right, and have also diagnosis can also be reached, but it is not the best. So if they ask you what is the investigation of choice for any mediastinal abnormality, remember, usually it is CT. Right, especially if we speak specifically of mediastinal tumors, then remember that for all mediastinal tumors, of course, for tumors contrast will be required, so contrast and CT will be the investigation of choice. But there is one exception to this, and what is that exception? That exception is posterior mediastinal lesions. Posterior mediastinal lesions. And posterior mediastinal lesions most commonly are what? Posterior mediastinal lesions most commonly are neurogenic lesions, right? Neurogenic tumors. And because they are neurogenic, we need to see whether they are extending into the spinal canal, whether they are affecting the spinal cord. And because we have to see this neural involvement, the investigation of choice for posterior mediastinal lesions is MRI. It is usually a contrast enhanced MRI. Alright, so first investigation, chest X-ray. Investigation of choice for most mediastinal abnormalities and mediastinal tumors is contrast enhanced CT, but specifically if your examiner asks you for posterior mediastinal lesions or mass lesions, it is contrast enhanced MRI. Yes, now let us look at certain specifics, right? Certain most commons as far as mediastinum is concerned. What is the overall most common mediastinal mass lesion? Most common overall mediastinal mass lesion is, remember, a thymoma. It is also, thymoma is also the most common anterior mediastinal mass lesion, because according to the mediastinal classification, Felson's or radiological classification we have studied, thymus gland lies in the anterior mediastinum. So thymoma is also the most common anterior mediastinal mass lesion. Most common middle mediastinal mass lesion, I told you the most common content of the middle mediastinum are the lymph nodes, the trachea, the esophagus, right? So most common middle mediastinal mass lesion, overall is a lymph nodal mass, Most common mediastinal mass lesion in children, if specifically this is something that is asked to you, then these are usually your foregut duplication cysts, most likely a bronchogenic cyst. Most common posterior mediastinal mass lesions are neurogenic tumors like neurofibromas and schwannomas, right? So these are the few most commons that you must know as far as the mediastinal tumors are concerned. Yes, now let us look at anterior mediastinal masses. Now when you think of anterior mediastinal masses, remember the 4 T's. What are 4 T's? We've just seen 1 T. What is that? What is the most common anterior mediastinal mass lesion? Yes, we've just discussed. It is thymoma. Then it could be teratoma, right? It could be a thyroid lesion. We discussed this, right? Retrosternal extension of thyroid into the mediastinum can give rise to a mediastinal lesion, that is thyroid lesions. And it could be terrible lymphoma. So this will help you remember this, right? What are the most common anterior mediastinal lesions? Remember 4 T's. Thymoma out of this is most common, teratoma, thyroid lesions, and terrible lymphoma. So these are most common anterior mediastinal mass lesions. Now let us look at thymoma. Now thymoma, we have discussed few most commons about thymoma. This is the most common mediastinal tumor overall. This is the most common mediastinal tumor overall. We have discussed that this is also the most common anterior mediastinal tumor. This is the most common anterior mediastinal tumor. This is also the most common tumor of the thymus gland in adults. There are certain important associations of thymoma. Now thymoma is associated with myasthenia gravis. Thymoma is associated with myasthenia gravis. Now what do you see here is basically this is a contrast enhanced CT. See, this is the aortic arch, And just in front of the aortic arch, you see a soft tissue lesion which is showing you more or less uniform homogeneous enhancement. So the enhancement pattern of thymoma is usually a uniform homogeneous enhancement. Now, when this uniform homogeneous enhancement is not seen, but something more aggressive is seen here, like you see central area of necrosis, or you see large cystic areas, or you see invasion into adjacent structures like the blood vessels, right, like the bone which is there anterior to it, then it is very likely to be a thymic carcinoma and not just a benign thymoma, right? So thymoma usually presents with uniform homogeneous enhancement, but if you see necrotic areas, if you see cystic areas, if you see evidence of invasion into the adjacent structures, then it becomes a thymus carcinoma or thymic carcinoma, right? So this is what you need to know about thymoma. Now see here, this was a patient who walked to my OPD, with a slight neck discomfort. A chest radiograph was done. And what do you see here? If you see here, the trachea, especially in the area of the neck, is severely deviated towards the left side. Why? Because there was a big mass lesion here. This big mass lesion was also known to have a little bit of retrosternal extension into the mediastinum. We did an ultrasound. There is a big thyroid mass lesion. It was biopsied and it turned out as malignant. Point is that thyroid lesions can also present as anterior mediastinal mass lesions because they can have a retrosternal extension down, right? And sometimes on imaging, if the retrosternal extension is small, the only imaging clue that you have is in the neck region. Now, there is an important sign or clue which helps us distinguish between anterior and middle mediastinal lesions. Now remember, most of the blood vessels, lie in the middle mediastinal compartment, and therefore when you see a lesion in the region of the hilum, if you see here, see, can you see a region in the hilum here? If you watch carefully through this lesion, inside this lesion, you are able to see the hilar vascular pattern. If you see that there is an overlay of a lesion, so there is a overlay of a lesion on the hilum, as is seen here, isn't it? So you can see that there is a lesion which is overlapping over the hilum. Then it means that lesion, right, is not in the middle mediastinum, because the pulmonary vascular markings lie in the middle mediastinum. So which means that this lesion is either anterior to it or posterior to it. It is most commonly associated with anterior mediastinal mass lesions. So this sign of hilum overlay, that is, whenever you see a lesion overlapping over the hilar shadows, the hilar shadows are therefore seen through and through, hilar vascular shadows are seen through and through that particular lesion, as in this particular image, then it means that the lesion cannot be in the middle mediastinum, because the vessels are in the middle mediastinum. The lesion is overlapping these vessels. So either the lesion is anterior or posterior. Most commonly, a hilum overlay suggests a anterior mediastinal mass lesion. So this is one sign that actually helps us localize the lesions, right, to the anterior mediastinal compartment. Now we come to middle mediastinal lesions. Now middle mediastinal lesions most commonly in children are, as we have discussed, these are what? These are the foregut duplication cysts. Most likely bronchogenic cysts or esophageal duplication cysts. Now, bronchogenic cysts will usually be located, in the middle mediastinum, close to the main bronchus or the trachea. Esophageal duplication cysts will be located close enough to the esophagus. Whereas in adults, we have discussed the content of the middle mediastinum, where apart from the trachea and the esophagus, we find that there are lymph nodes which are there, and therefore in adults, the most common middle mediastinal masses are lymph nodal masses. Either it could be lymphoma or it could be multiple tubercular nodes as well. Now here was a patient which we found had, a very large lesion which was extending across the compartments of the mediastinum. It was a large lymph nodal mass lesion suggestive of lymphoma. We could see lesions overlapping over the hilum, going even above the clavicle. If a lesion goes above the clavicle, remember, it is suggestive to be extending into the posterior mediastinum, because remember, the anatomy of mediastinum is such that the anterior mediastinum usually ends at the level of the clavicle. So if you see a lesion extending above the level of the clavicle, then it usually means that it could extend, or it is in the posterior mediastinum, because it extends high up, right up to the lung apex. This is what is called as the cervicothoracic sign. So cervicothoracic sign helps us distinguish from an anterior and a posterior one. It says that anterior mediastinum ends at the level of the clavicle, but posterior mediastinum extends above the clavicle level. Therefore, if a lesion here, as you can see here, it is extending above the clavicle, so it means that there is extension into the posterior mediastinal compartment. It has a lobulated contour, it has a hilum overlay, so it is occupying the anterior, middle, as well as posterior mediastinum. Along with it, there is encasement of the mediastinal great vessels. Also, this is highly suggestive of lymphoma or a lymph nodal mass lesion. It is showing diffuse low level uniform enhancement, no heterogeneity, which is seen on this post contrast CT study as well. So a lesion which extends across the multiple compartments shows uniform low level homogeneous enhancement, right? No heterogeneity extending across the mediastinal compartments, suggests a lymph nodal mass or a lymphoma, right? So this is a very peculiar feature. Now posterior mediastinal mass lesions. Now posterior mediastinum basically comprises of what? It comprises of posterior mediastinal contents are basically nerve roots, the sympathetic ganglia or roots. It consists of the thoracic duct, it consists of the aorta, right? So what are the most common mediastinal masses? The most common posterior mediastinal masses are therefore neurogenic tumors. Remember, now the investigation of choice for all the mediastinal lesions we have discussed is a contrast enhanced CT, except for posterior mediastinal masses, because they are commonly neurogenic, and therefore contrast enhanced MRI is usually considered to be the investigation of choice for posterior mediastinal lesions. Now see here, this was a huge lesion, right, which was even extending above the clavicle. Here, see, this is the clavicle, so it is extending above the clavicle in the paravertebral location. This was very typical of a posterior neurogenic lesion. See, this was a lesion which was extending into the neural foramen of the spinal canal. See here, it is causing widening of that particular foramen there. So here you can actually see the lesion extending out of it. Right now, these neurogenic tumors, because they can arise from the spinal cord, pass through the neural foramen and then come out, they can give rise to a dumbbell shaped. So one component is inside the canal, there is a narrowing across the neural foramen, and another large component is on the outside of the neural foramen. So this gives rise to a dumbbell shaped appearance, which is very typical for a neurogenic tumor. Though there's another sign which is associated with peripheral neurogenic tumors and not usually central, and that is called as the target sign. So target sign is usually seen in peripheral neurogenic tumors. Peripheral neurogenic tumors, where on T2 weighted images you can see that the periphery of the lesion appears bright, whereas the center of the tumor appears dark, giving rise to a target shaped appearance. So this is what is called as the target sign of neurogenic tumor. So neurogenic tumors are predominantly in the posterior mediastinum. Investigation of choice is usually contrast enhanced MRI. They can present as a dumbbell shaped tumor. We can see them extending into the neural foramen, may be arising from inside the spinal canal. They may have a dumbbell shaped appearance or a target appearance. Now let us look at a specific clinical situation, a combination of, what do you see here? Look at this coronal MRI image. You can see that this vertebral body is actually normal. See, this vertebral body is normal. This vertebral body is normal. There are intervening discs. But look at the intervening vertebral body. What do you see? You see that the central part of the vertebral body is hypoplastic. There appears to be sort of a cleft, right? And this shape is called as a butterfly vertebra. So this is basically a vertebral segmentation defect. So patient presents with vertebral segmentation defect or anomaly, either in the form of a butterfly vertebra here or in the form of a hemivertebra where only half of the vertebra will be formed. And if along with a vertebral segmentation anomaly, you see a posterior mediastinal cystic lesion, then the diagnosis becomes a specific clincher, and that is called neurenteric cyst. Neurenteric cyst. So remember, this combination of a posterior mediastinal cyst or lesion along with vertebral segmentation anomalies clinches a specific diagnosis, and that diagnosis is neurenteric cyst. Remember, this is a very typical combination. Now let us move on to another mediastinal abnormality, and that is pneumomediastinum. What does it mean? It means air within the mediastinum. It means air within the mediastinum. Now see, the first investigation though for diagnosis of pneumomediastinum can be a chest X-ray. Is it good for a diagnosis of pneumomediastinum? No, it is not, because the mediastinal structures, that is mainly the heart, is as it is surrounded by air-filled lungs. So it is very, very, very difficult to depict free air within the mediastinum on a chest X-ray. And so what will be the investigation of choice? Remember, we discussed the concept. Fluid is friend of ultrasound. Air is enemy of ultrasound. So here we want to detect air. Can ultrasound be used? No. Wherever ultrasound fails, what is the next best investigation available? It is CT. So remember, anywhere in the body you want to detect minimal quantities of fluid, the best investigation will be ultrasound. Anywhere in the body you want to detect minimal quantities of air, like pneumothorax, pneumomediastinum, pneumoperitoneum, the investigation of choice is going to be CT. Now let us look at what features can actually present on a chest radiograph in cases of pneumomediastinum. Now see here, alongside the heart here, you are able to see some streaky lucencies there. One important clue which is almost always seen on an erect chest radiograph in pneumomediastinum is that there will be air in the base of neck soft tissues. This is a very important clue. Why? See, though in anatomy you must have studied neck separately and mediastinum separately, right? Actually, there is no partition that separates the neck from the mediastinum, and therefore we have already discussed that a thyroid lesion can actually go down into the mediastinum. If a neck lesion can go down into the mediastinum, a mediastinal abnormality can also rise up, and therefore whenever there is free air within the mediastinum, air always has a tendency to rise up. There is no partition separating the mediastinum and the neck. So what happens? This air almost always rises up and is seen at the base of neck soft tissues. So whenever you suspect pneumomediastinum, do an erect chest radiograph and always pay attention to the base of neck soft tissues. This is the area where identifying air becomes relatively easy, and therefore the diagnosis of pneumomediastinum can be clinched. Traditionally, in the olden days when CT scan was not available, right, there are multiple named signs and appearances have been described on X-rays. So let us quickly have a look at them. One such sign is called spinnaker sign or angel wing sign. What is this? Now see, we all know that in children in the pediatric age group, the thymus gland is very prominent. Thymus gland shadow is prominent because the size of the gland is larger. Though the thymus gland is prominent, how is it seen on an X-ray? It is seen as a widening of the superior mediastinum, which is considered to be a normal feature in pediatric age group. But though the thymus gland is large, prominent, we never see the sharp margins of the thymic lobes because it merges with the mediastinal soft tissue. But what happens in pneumomediastinum? In pneumomediastinum, because there is free air within the mediastinum, this free air lines the thymus gland. And because it lines the thymus gland, differential radiographic density theory creates a sharp margin, and therefore we are able to see a very sharp margin of the thymus gland lobes. This is the right lobe, this is the left lobe. They look like wings. So what is it? This is given a name. This is called angel wing sign or spinnaker sign. Now see, when we discussed the diaphragm, I told you that see, this is the same radiograph, but see, there's another sign which is here. When we discussed the diaphragm, right, I told you that we see the right dome of diaphragm as a sharp margin. We see the left dome of diaphragm as a sharp margin. What part of the diaphragm do we not see as a sharp margin? That is the central tendon. Why? Because the diaphragm is water density. What is sitting on the central tendon of diaphragm is heart. Heart is also water density. Because they have the same densities, sharp margin is not seen. But what happens in pneumomediastinum is that this free air which is present sometimes goes and gets trapped between the base of the heart and the diaphragm, central tendon of diaphragm. So now differential radiographic density theory creates a sharp margin. If we try tracing the diaphragm from the right CP angle to the right cardiophrenic angle, we can actually trace a sharp margin across the midline to the left costophrenic angle. This continuous tracing of the diaphragm is given a name. This is called continuous diaphragm sign. See here, we are able to see a tracing of the diaphragm continuously. There is a lucent band which is present below the base of the heart, above the central tendon of diaphragm, because the air has gone and got trapped there. This is continuous diaphragm sign, which is seen in pneumomediastinum. Another few signs have been described. One such sign is called as Nacclerios V sign. What is Nacclerios V sign? If you see here, see, there is a V-shaped lucency which is seen because air is lining the lateral margin of descending thoracic aorta and the medialmost margin of the left hemidiaphragm. So this V-shaped lucency is what is called as Nacclerios V sign. Nacclerios V sign has been described in pneumomediastinum due to esophageal rupture. Though it has traditionally been described in association with esophageal rupture, it is not specific for esophageal rupture. It can be seen in pneumomediastinum due to any cause. Another finding, which a few more findings that have been described in pneumomediastinum include the tubular artery sign, ring around the artery sign, double wall bronchial sign, so on and so forth. Most important signs are the Spinnaker sign, angel wing sign, continuous diaphragm sign, and Nacclerios V sign that we have discussed. Yes. Now, whenever we see a solid lung lesion, right, depending upon the size of that particular lesion, we classify it and the terminology used is different. If the lesion size is less than 3 centimeters, then it is described as a nodule. If a lesion size is more than 3 centimeter, then we describe it as a mass. So when do you call it as a nodule? We call it as a nodule when the size is less than 3 centimeters. We call it as a mass when the size is more than 3 centimeters. So whenever you see a mass, it always has to be evaluated further by doing a PET scan or either doing a biopsy, because we want to rule out malignancy. What if we see a solitary nodule less than 3 centimeter in size in the lungs? This condition is given a name. It is called solitary pulmonary nodule. So what is a solitary pulmonary nodule? As the name suggests, it is a single nodule within the lung. Nodule by definition has a size of less than 3 centimeters, isn't it? Look at this chest x-ray. See, there is a nodule which is seen here. Size was measured less than 3 centimeters. Right. So initial investigation, right? So what is the definition? We've already seen the definition. Definition is a single less than 3 centimeter sized solid lesion, or lesion which is less than 3 centimeter in size, single, is called SPN. What is the first investigation? The first investigation for characterizing or detecting, many times, as in this case, in this patient, we detected this SPN by doing what? By doing a chest x-ray. Right? But is it the best? No. Right? The best investigation or investigation of choice, therefore, for assessment of SPNs is usually a contrast enhanced CT, which is sometimes even considered better than a PET CT. If contrast enhanced CT is not available in the options, then you can select PET CT, but overall the best is CECT. What is the main concern here? The concern here is that whether it could be a malignancy that we have detected earlier on, right? So we want to rule this out, and therefore what do? We do a CECT. On CECT, it is assessed on multiple parameters. What is the size, shape, location, margins? Is there any calcification? Is there any cystic change? How is it enhancing? How is it growing on interval CT? Right? So based on all this, we classify it either as low risk, intermediate risk, or high risk for malignancy. If it is low or intermediate risk, it can safely be followed up. But if the imaging findings suggest a high risk for malignancy, then we usually have to biopsy it. So this is how the management of solitary pulmonary nodule is. A question was asked recently based on solitary pulmonary nodule. See, a 25-year-old male presents with a solitary pulmonary nodule on chest X-ray, and CT shows what? CT shows a lung nodule with coarse calcification. Look at this CT here. This is a post-contrast CT. Look at the aorta there, right? It is showing contrast. It is appearing hyperdense. On this CT, can you see this nodule there? It is showing multiple, multilobulated coarse calcification. It has a lobulated contour like this. So this appearance of coarse calcification has been described as what? It has been described as popcorn calcification. So popcorn calcification within the lungs is a feature of a benign lung tumor called as pulmonary hamartoma. So this is classical of pulmonary hamartoma. Pulmonary hamartoma is a tumor-like lesion within the lung, which is actually an abnormal mixture of mature tissues. It is associated with a specific triad, which is called as the Carney's triad. What is this Carney's triad? It is associated with multiple lung hamartomas. It is associated with gastrointestinal stromal tumors or GISTs and functioning paragangliomas or pheochromocytomas. Okay, so this is what is the Carney's triad. Yes. Now, if we come to assessment of lung tumors or a mass lesion more than 3 cm in size, first investigation as usual is chest X-ray. Is it the best? No. So the best investigation is contrast enhanced CT because it helps us characterize it. But there is one exception to this, and this was the question which was asked when we started with the clinical quiz, isn't it? What is that exception? That exception is basically a lung tumor called as Pancoast tumor. Because for Pancoast tumor, there is neural invasion into the cervical sympathetic ganglia, into the brachial plexus nerve roots. And which modality, CT or MR, has a better soft tissue contrast resolution? Which modality can better show us neural invasion? It is of course MRI. And therefore for Pancoast tumor, the investigation of choice is contrast enhanced MRI. Yes, so this is what is the imaging protocol for lung tumors. PET CT can also be used. PET CT is usually used to look for distant metastasis and staging of the tumors. Now let us look at certain specifics as far as lung tumors are concerned. Many of the points that we are going to discuss here, you will also cover in pathology, where lung tumors will be discussed in much more detail, right? We'll just quickly go through these specifics because each of them is actually a potential MCQ. The various histopathologic subtypes of lung tumors could be adenocarcinoma, squamous cell carcinoma, bronchoalveolar carcinomas, right? Let us have a look at them one by one. So adenocarcinomas, remember, they are usually peripheral in location. Remember, A for adeno, A for away. So they are peripheral in location. They are the most common type overall and as well as the most common type in women. So that is the important factuals you need to know about adenocarcinoma. Whereas squamous cell carcinomas are usually central, S. So central, they remember they are more or less central in location. Most common type to show cavitation, right? So central in location, most common type to show cavitation. It is most commonly associated with Pancoast tumors and it is the most common cancer in smokers. So squamous cell is seen in smokers. It is central in location, shows cavitation and is associated with Pancoast. Now there is a slightly atypical type of lung cancer and that is called bronchoalveolar carcinoma. This is also called as adenocarcinoma in situ. This is also called as adenocarcinoma in situ. Now, this is associated with, or this usually originates from type 2 pneumocytes. It usually presents as consolidation or air bronchogram, see, which mimics infection, right? And therefore, it usually presents as non-resolving infection or non-resolving consolidation on imaging. And it has a very peculiar property of endobronchial spread. This is also called as lipidic pattern of spread. Lipidic pattern of spread. This is also called lipidic pattern of spread. Now, one of the most aggressive subtypes. So, the most aggressive subtype of lung cancer is called small cell lung cancer. So this has the fastest growth, therefore it has the worst prognosis. It is usually central or perihilar in location and presents with paraneoplastic syndromes. It has necrosis within it and shows SVC obstruction. So worst prognosis is small cell lung cancer. Recently a question was asked, that is prophylactic craniospinal irradiation is done in which type of lung tumor, and the answer was small cell carcinoma. Because this is the aggressive subtype, it usually presents with distant metastasis. It has a big propensity to spread to the neuraxis, that is the brain and the spine. So once this particular type of cancer is detected, even prophylactic craniospinal irradiation is usually chosen. So this is what is about lung tumor specifics. Now look at some images. Now, lung tumor can simply present as a lobulated or a solid appearing lung mass like this, or more commonly, it gives features of malignancy such as a corona radiata like appearance. So this is called as the corona radiata appearance. Means what? In corona radiata appearance, if you see here, there are extensions of the tumor within the adjacent lung tissue like this. So it is like a spiculated kind of an appearance because there is extension into the lung parenchyma. Whenever you see a hilar lesion with evidence of slight elevation of the hilum, so see there is significant difference between the levels of the right and the left hilar, then it usually indicates phrenic nerve involvement. So you see a hilar tumor or a hilar lesion, it has an aggressive appearance, a corona radiata like appearance, and there could be phrenic nerve involvement that is indicated by elevated dome of diaphragm, ipsilateral dome of diaphragm, elevated ipsilateral dome of diaphragm. So this could be an indirect sign. Right now, in certain specific type of lung tumors, there is a specific history clincher. What is the history clincher? Let us have a look. So elderly male with a chronic smoker, presence with complaints such as cough, hemoptysis, weight loss. On a radiograph, there is a mass-like lesion which is seen where? In the lung apex. So say example at the left lung apex, there is a mass-like opacity which is seen. Now, if there is an opacity at the left lung apex on imaging, the patient presents with left-sided Horner's syndrome, meaning there is invasion of the cervical sympathetic ganglia. Patient has ptosis, anophthalmosis, anhidrosis, all these features of Horner syndrome. Patient also develops left upper limb pain, paresthesia and weakness. So all this put together, if you see that there is an elderly male chronic smoker, this predisposes to malignancy. You see a lesion in the lung apex, patient has cough, hemoptysis, could have weight loss. Left apical lesion presents with left Horner syndrome due to invasion into the cervical sympathetic ganglia. Due to invasion into the brachial plexus nerve roots, there will be upper limb pain, paresthesia, weakness. All this put together clinches the diagnosis of Pancoast tumor. Pancoast tumor. What is Pancoast tumor? It is also called as superior sulcus tumor. This is also called as superior sulcus tumor. Okay, what is this? This is nothing but a malignancy in the lung apex. So look at this chest radiograph. You can see a mass lesion in the lung apex. Why is it malignant? Even before knowing any clinical history, I can say it is malignant because look at the ribs on the right side here. Ribs are very well seen. If you look at the ribs in the left lung apex are completely destroyed. Whenever you see bony erosion, whenever you see bony destruction, then remember that it means that the lesion is malignant because it has invaded and destroyed the bone. The investigation of choice for Pancoast tumor, we have discussed before also, is contrast enhanced MRI, because we want to look for neural invasion into the cervical sympathetic ganglia, into the brachial plexus nerve roots, and MRI has a much better soft tissue contrast resolution and therefore it is better seen. This was a CT which was done in one patient, which shows that there is an apical lesion, there is bony erosion which is there, which is clearly apparent into these ribs, and therefore this is also a Pancoast tumor. A very specific appearance can present like this. See, 75-year-old male, elderly male, known case of renal cell carcinoma. This CT reveals what? Are these miliary nodules? No, miliary nodules are tiny, discrete 1 to 3 mm nodules. What do you see here? You see multiple large nodules in both lung fields. So what is this? This is suggestive of cannonball lung metastasis. The name also indicates that it is a very aggressive condition. It is seen in aggressive tumors. Most commonly, it can be seen in RCC. It can be seen in choriocarcinoma, germ cell tumors, endometrial carcinoma, prostate cancer as well. Right? So cannonball lung mets is a feature of aggressive disease. Most commonly it is seen in RCC. It can be seen in choriocarcinoma, germ cell tumors, endometrial carcinomas, or prostate CS as well. So this is hematogenous spread of the cancer to the lungs, forming multiple large cancerous deposits. Okay, now look at this condition here. We are going to follow a clinical scenario based approach so that you are also prepared for your MCQ. So let us see. This is a middle-aged female. Presents with what? Persistent cough and expectoration, intermittent hemoptysis. So something is the cause for this persistent infection. What do you see here? She also has recurrent chest infection. So all this point towards an underlying structural cause as to why she is recurrently, having these infections. If you watch this chest X-ray carefully, look alongside the heart. Can you see multiple round cystic lucent areas? Multiple round cystic lucent areas on both sides tell us that the bronchi are basically dilated. See, multiple of them tells us that bronchi are basically dilated. What are irreversibly dilated bronchi called as? Irreversible bronchial dilatation due to the destruction of the walls is termed as what? Is termed as bronchiectasis. Right, is termed as bronchiectasis, and it is this abnormal dilatation of the bronchi is what is the underlying structural predisposing cause as well as the effect of recurrent infections. Right, so there is stasis of secretions there, right, which get infected, so that is giving rise to this vicious cycle. So this is how bronchiectasis usually presents. So if you see, first investigation in bronchiectasis, as we can see here, is usually a chest X-ray, but the best investigation is usually HRCT. As we have seen in this radiograph, there are multiple round lucent lesions which are seen, which show a thick wall. Look at this CT image again. Can you see these air containing areas? A cyst within a lung on an HRCT always has very thin walls, remember. But when you see an air-filled cystic lucency with extremely thick walls, remember, then it is not a cyst. It is usually a dilated bronchus, and that is a feature of bronchiectasis, right? And you see here, all of these show a significantly thick wall. So what are these? These are nothing but dilated bronchi. This is bronchiectasis. There are various named appearances and signs that have been described. This clumped appearance of the bronchi on CT is called as a bunch of grapes sign. This is called as the bunch of grapes sign. Now suppose that there are linear along the long axis of the bronchus, you see dilated vessels like, or dilated bronchi like this, right? The dilated bronchi with straight walls like this, they are called as the tram track appearance of the bronchi. If there is varicose dilatation of the bronchi like this, varicose dilatation of the bronchial wall, this is what is called as the string of beads appearance. Now normally, if you see in the lung, a blood vessel which appears white like this and a bronchus is of a similar size. But when the bronchus becomes dilated, what will happen? Blood vessel is of the same size as before, but the bronchus is dilated. What is this? This is called as the signet ring appearance. This is what is called as the signet ring appearance. So this is the bunch of grapes or cluster of grapes that also we have seen. Now suppose that a a dilated bronchial segment, it gets filled up with fluid, then that condition, if it is filled up with fluid, so a bronchiectatic segment filled up with fluid is called bronchocoele, right? It is called bronchocoele, and this is what gives rise to gloved finger-like appearance. Like, right, when you've worn some gloves, right, one finger looks, a smooth in outline, right? So that is called as gloved finger appearance. Gloved finger appearance of bronchocoele when there is fluid which is filling up this bronchiectatic segment. So this is all that you need to know about bronchiectasis. Now see here, this was a recently asked question. A 35-year-old female, right? So this is a middle-aged female, presented with what? Fever, weight loss, elevated angiotensin converting enzyme level. So this is a clincher for sarcoidosis, remember. Can it be tuberculosis, right? But tuberculosis will not show elevated AC enzyme. Elevated AC enzyme is a clincher for sarcoidosis. Chest X-ray reveals bilateral convex hilar shadows because there is bilateral hilar lymphadenopathy in sarcoidosis. So the diagnosis here is sarcoidosis. What are the clinical features, or what are the specific features, imaging features of sarcoidosis? See, convex appearing hilum. Why? Because there is of lymphadenopathy. So bilateral hilar and paratracheal lymphadenopathy is a peculiar feature of sarcoidosis, right? Sarcoidosis is basically characterized by non-caseating granulomatous. It is a non-caseating granulomatous multisystemic disorder, involves a lot of systems, lungs are involved, right? This bilateral hilar lymphadenopathy along with paratracheal involvement gives rise to various signs. These signs are called lambda sign, 1-2-3 sign. It is sometimes called as the Garland's sign. So lambda sign, 1-2-3 sign, Garland's sign, pawnbroker sign, right? On gallium scan, various signs have been described. So in gallium scan in sarcoidosis shows hot spots. Before we go there, look at this X-ray. We have seen hilar lymphadenopathy. See, look at this CT also. Can you see this round nodular deposits right at the hilum there? So these are bilateral hilar lymph nodes. On a gallium scan in sarcoidosis, hot spots are seen at the site of involvement. This gives rise to very classical appearance. What is this? One is called as the face of panda sign or panda sign. Why is this panda sign seen? Because there is uptake of gallium seen within the lacrimal glands and also seen within the parotid glands. This is superimposed upon this central normal uptake within the nasopharynx, right? So lacrimal gland uptake, parotid gland uptake, and a normal, uptake in the nasopharynx in the center. This is what gives rise to the panda sign. There's another sign which is described in sarcoidosis on gallium scan, that is called lambda sign. What is this lambda sign? See here, this is the right paratracheal lymph node which is involved. This is right hilar lymph node which is involved, and this is the left hilar lymph node which is involved. So right paratracheal, right hilar and left hilar lymph node involvement gives rise to this lambda shaped appearance. So this is what is called as the lambda sign. Now see here, very typical clinical scenario. A 2-year-old child. So a child presents with what? Presents with sudden onset breathlessness, wheezing, and hyperlucency involving the right hemithorax. See, even if the question ended here at wheezing, I should get the diagnosis. Why? Because remember, it is a history clincher of child presenting with acute onset respiratory distress. If a child, this is a history clincher, remember, in your entire life of clinical practice going ahead, as well as in your exams, if you ever come across a child who presents with acute onset respiratory distress, then it points to one diagnosis, and that is foreign body aspiration. Yes. So remember, this is a history clincher of, foreign body aspiration, child with acute onset respiratory distress. Can you tell me what is the most common foreign body to be aspirated? Yes, you would think it is a coin, but it is not a coin. Remember, a coin is something that we see very prominently and therefore we remember it, right? But coin is not the one which is most common to be aspirated. Most common one to be aspirated is a peanut or a groundnut. And this peanut is radiolucent, so we don't see it on an X-ray. So what do we see? See, if a peanut is lodged within a bronchus, during inspiration, as the bronchus dilates, air can pass into the lung. But during expiration, as the bronchus has a tendency to collapse, this peanut is going to completely block the bronchus. So the air within the lungs will not be able to escape the lungs, right? And therefore there will be air trapping. So on chest X-ray, there could be air trapping. So as you can see on this radiograph, can you see that the left lung field, though it is showing some vascular markings within it, it is appearing excessively black. So that is because of air trapping. In advanced cases, what happens basically is that going ahead, the lung can get completely collapsed. So air trapping, it will appear black or excessively lucent like this. But if the entire lung collapses going ahead, then the entire lung will appear opaque due to lung collapse. That particular lobe or the lung may entirely collapse. Okay, all right. Now see, this was a child. So previously we saw a child with acute onset respiratory illness, right? We did not see a foreign body, but we saw air trapping, right? So that was suggestive of foreign body aspiration. Now this child, we see something very prominently here, but he does not have respiratory distress. He has mild discomfort in the neck region and difficulty in swallowing. What does it tell us? It tells us that this particular lesion is not within the trachea, but it is very likely to be in the esophagus. This coin that we see here is not likely to be in the trachea, but it is in the esophagus. Why? One reason is the clinical history. There is no respiratory distress, right? If this coin was there in the trachea, it would have got respiratory distress. Another reason is the orientation of the coin. Now see, if you look at the glottis from the top, what is the glottis bound by? The glottis is basically two vocal cords like this. So the opening is here in the mid-sagittal plane. So if a coin has to pass through the glottis into the trachea, how will it have to pass? The coin will have to be oriented in the sagittal plane. Only then it can pass through this slit-like opacity. When it will go into the trachea, it is held in this sagittal plane by the tracheal ring of cartilages, right? So therefore, right here, the coin that you are seeing is not in the sagittal plane, but you are seeing it en face. So it is in the coronal plane. Can a coin enter and remain into the trachea in a coronal plane? The answer is no. See, look at the glottis. The opening of the glottis is a tiny slit-like opening in the sagittal plane. So firstly, this child does not have respiratory distress. Secondly, the orientation of the coin is coronal. Both these findings tell me that this is very likely to be in the esophagus. If it is in the trachea, then the child would have severe respiratory distress and the coin would not be seen en face, but it will be seen as a slit-like opacity because then it will be in the sagittal plane in the body. Yes, so this is a very important clinical situation. Now, therefore, in this discussion of mediastinal lesions, lung tumors, what are the insights that we get? Remember, in mediastinum, it is logical and simplifying to go by a chamber-based diagnosis. So we have discussed in what chamber, what structure lies, right? So depending upon the location, we can actually narrow down to a differential diagnosis. Like if we see a lesion which is homogeneously, uniformly enhancing in the anteromediastinum anterior to the great vessels in the prevascular space, it is very likely to be a thymoma. But if I see a large lobulated middle mediastinal mass lesion that extends across the compartments, then it is likely to be a lymph nodal mass. Posterior, because I know the main components in the posterior mediastinum are neurogenic components. The most common posterior mediastinal mass is neurogenic tumors. Investigation of choice for all mediastinal masses is contrast enhanced CT except posterior mediastinal masses, because they are neurogenic. The investigation of choice is contrast enhanced MRI. We have seen various signs. We have seen dumbbell appearance. We have seen target signs of neurogenic tumors. For lung tumors also, again, investigation of choice for lung tumors is contrast enhanced CT except for Pancoast, for which it is a contrast enhanced MRI. Pancoast is lung apical tumor. We have seen the history clincher of Pancoast tumor. Sarcoidosis is a multisystem disorder, right? We have seen the most important radiological feature is bilateral hilar lymphadenopathy, right? And on gallium scan, we have seen peculiar features. What are those? Panda sign and lambda sign. Right, these are specific features on gallium scan. So a child with acute onset respiratory distress is what? This is a history clincher. This is foreign body aspiration. Right, we have also discussed quickly, when you see a coin, where if it is coronal plane, right, in the coronal plane it is very likely to be in the esophagus. If it in the sagittal plane, it is very likely to be in the trachea. The clinical presentation will also be different, right? So look at this. This we have seen multiple times now in this discussion. Elderly smoker, presence with hemoptysis and cough. Chest X-ray shows left apical mass. He has left Horner syndrome and left upper limb pain, paresthesia and weakness. So this is classical of Pancoast tumor. This is very typical of Pancoast tumor. All lung carcinomas for diagnosis require CECT thorax, but MRI is useful for, again, Pancoast tumor. We have discussed this, to look for neural invasion, right? And a 35-year-old female presents with fever, weight loss, elevated AC enzyme levels is clincher for sarcoidosis. Bilateral convex appearing hilar lymph nodes presence results, or this is a feature of sarcoidosis. Yes.